Hello, I'm David Kerr, Professor of Cancer Medicine at the University of Oxford. I have a lifetime career interest in trying to understand better the biology, the genetics, and ultimately the treatment of colorectal cancer. And what I'd like us to do collectively is just to stop for a moment and stand back in awe and wonder at the extraordinary advances that have been made in modern medicine. I mean, just stop for a moment, wonder with me, and walk with me as I take you through a protocol I was just looking at for the treatment of patients with Lynch syndrome. Lynch syndrome is the most common hereditary colon cancer syndrome. These are caused by germline mutations in one of 4 mismatched repair genes, and these carry a population prevalence of around 1 in 300. Patients with Lynch syndrome have, at the most extreme, a lifetime risk such that 80% of these individuals will develop colorectal cancer. So it's a hugely important problem. Many years ago, more than 20 years ago, I served on the clinical trial advisory committee with a great friend, John Byrne, who did some really fantastic work in the early days, and he looked at the impact of dietary starch and aspirin in trying to prevent the occurrence of colorectal cancer in those patients who carried the genetic abnormalities, who had Lynch syndrome. So more than 20 years ago, we were looking at starch and aspirin to try and prevent the occurrence of colorectal cancer. Looking at this, the protocol that I've been looking at recently, I mean, goodness gracious. So this is looking at a recombinant trivalent adeno-5 vaccines in combination with an interleukin-15 superagonist acting as an immune stimulant. I mean, what? This is extraordinary. So this is a very beautifully genetically engineered replication deficient adenovirus being the common cold. So the adenovirus has been so designed that it can be given repeatedly. One of the early problems when we had our own gene therapy program was that we would generate antibodies to the therapeutic virus really quickly, neutralizing it. This antibody can be given 4, 5, 6 times without serious immune interference. So this allows a trivalent vaccine to be given. And so the adenovirus has had engineered into it as antigens, CEA, carcinoma embryonic antigen, that's been tweaked to make it a super antigen. That makes it even more likely to be recognized by the immune system. MUC1, this is a well-recognized, again, tumor-associated antigen. It's a glycoprotein, well characterized in the literature for many, many years. And a clever homologue of brachyury, which functions as a sort of T-cell stimulant. It's a transcription factor that's been modified to, again, magnify T-cell responses. And in addition to that, again, there's a very clever construct of an IL-15 superagonist, which one would hope would, again, enhance the T-cell response, particularly with memory. A fantastic trial. I've given you the link to clinicaltrials.gov to have a look at the protocol. Great investigators, great centres, very sensible randomised phase 2 trial design. But goodness gracious, we've gone in 2 decades from starch and aspirin to these incredibly sophisticated approach of vaccinating these Lynch syndrome patients with a view to preventing the occurrence of colorectal cancer, such that if, because of the mismatched repair gene defects these folk have inherited, if a colorectal cancer cell pops up, then they will have been pre-vaccinated using some very logical tumor antigens. I mean, modern medicine. I mean, so fingers crossed that it works. You know, some very excellent preliminary data, preclinical, clinical safety, and so on. But just got to marvel. He genuinely got to marvel at the sophistication of the approach, and wish the investigators well. Um, have a look at the protocol. It's science fiction made real. Um, Tell me what you think about it, and I'm grateful for any comments or anything that you might like to say. For the time being, Medscapers ahoy, and thank you.